What if the way you sleep tonight is quietly making your heart work harder and slowly increasing your risk of a dangerous blood clot or stroke? It sounds dramatic, but there's mounting evidence and a straightforward mechanical fix you can try this week. I'm Dr. Blake Harrison. I've been a cardiologist for over 20 years, and I've seen how small, low-cost changes in how people sleep can translate into real improvements in circulation, fewer symptoms, and, yes, potentially lower risk of clot-related events over time. In this video, I'll explain the why, how, and exactly what to set up tonight, the position, and the precise adjustments that research and clinical experience suggest may reduce the forces that contribute to clot formation and nocturnal cardiovascular events. If you want reliable, evidence-based tips for senior heart health, subscribe now, and I'll share more practical ones every week. As we age, the body's plumbing changes. Arteries stiffen. The lining that helps blood vessels relax produces less nitric oxide, and veins and lymphatics don't clear fluids as efficiently as they once did. Those are normal biological facts, not moral failings. Add to that the way gravity, anatomy, and mattress pressure work on the chest, abdomen, and hips during sleep, and you have a situation where blood can pool, lymphatic drainage can be impaired, and pressure patterns inside the chest change in ways that encourage clotting in susceptible people. Clinical journals from sleep medicine and cardiology have drawn attention to the link between sleep disturbances, nighttime blood pressure behavior, and cardiovascular events. See Journal of Clinical Sleep Medicine, JCC, Hypertension, NEJM, for broader cardiovascular epidemiology. Those papers don't prove a single position will be perfect for every person, but they do point to mechanical contributors that we can modify without medications. Here's the core idea in plain language. Some sleeping positions compress the chest or twist major blood vessels just enough to slow venous return from the legs and kidneys and to alter the pressure the heart must pump against. Think of it like a garden hose that gets a kink. The flow drops, pressure upstream rises, and blood hangs around longer where clots are more likely to form. Other positions worsen sleep-disordered breathing or create nighttime blood pressure that fails to dip appropriately, which is itself associated with higher cardiovascular risk. Studies in Hypertension and Journal of Clinical Cardiology discuss the non-dipping phenomenon. What we can do is use gravity and careful padding to make the circulation more efficient during the hours we can't monitor it. 3 common positions silently contribute to these problems, and I want to be clear about what they do. Sleeping on the stomach compresses the chest and limits how the diaphragm and heart move during breathing. That can reduce cardiac output and make breathing shallower, worsening oxygenation and sometimes sleep apnea. Sleeping flat on the back, supine, can promote airway collapse in people prone to obstructive sleep apnea and is associated with non-dipping blood pressure overnight, a pattern linked with higher rates of heart attacks and strokes in observational studies. See Journal of Clinical Sleep Medicine. And while sleeping on the right side is often assumed to be harmless, it can create a mechanical angle on the aorta and impede lymphatic drainage from the left-sided circulation. On the right side, the configuration of the major veins and the curvature of the aorta may create relative stasis in some older adults, which is why several vascular and sleep studies have raised the right side position as less favorable in people at risk of clots. See JVasc-Serg, Frontiers in Aging Neuroscience. Each of these positions has plausible physiological reasons to be less ideal for seniors who already have vascular stiffness, reduced nitric oxide, or a history of clotting. Now, the solution I recommend for most older adults who do not have a specific contraindication is straightforward. Favor the left lateral position, sleep on your left side, combined with a modest elevation of the upper body and targeted supports to keep the hips and rib cage aligned. When done correctly, This arrangement uses gravity to help venous return from the legs, reduces compression of the heart and major veins, encourages lymphatic drainage, and minimizes the aortic geometry issues we worry about with right side and supine sleeping. Evidence from sleep medicine and cardiology journals suggests these mechanical factors can influence nocturnal hemodynamics. See Journal of Clinical Sleep Medicine, JACC, and clinical protocols published in 2023 have begun to standardize positional recommendations for at-risk older adults. I'll give you the exact measurements and a step-by-step setup in a moment. Before that, I want to emphasize caution. Changing how you sleep is generally low risk, but there are important exceptions. If you've had a recent stroke, pulmonary embolism, heart operation, major orthopedic surgery, have severe COPD or oxygen dependence, or if you are on blood thinners for a recent clot, discuss any major positional changes with your treating physician. Do not stop or change medications without medical advice. This recommendation is about reducing mechanical stress during sleep. It does not replace anticoagulation, blood pressure control, or other therapies your team prescribes. If you're ready to proceed, here is the exact protocol I recommend. This is the setup I describe to my patients who ask for practical steps they can implement immediately. First, the key elements: left side sleeping, upper body elevation of roughly 15-20 degrees, head of bed elevation in the range of 7 to 9 inches, a firm knee pillow between the knees, a small rib cage support under the left lower ribs, a medium-thickness pillow for neutral head alignment, and a pre-sleep leg elevation for 15 minutes, about 30-60 minutes before getting into bed. Do not exceed about 25 degrees of inclination. You want modest elevation, not sitting upright like in a recliner, because excessive elevation transfers pressure and can create neck strain and other problems. Equipment specifics: use a foam wedge designed for torso elevation or sturdy bed risers that lift the head of the mattress evenly. Avoid stacking loose pillows under the head. The most important change is lifting the torso, not just the head, because head-only elevation often leaves the chest and diaphragm in a position that still encourages airway collapse and venous congestion. For the knee pillow, choose a firm, contoured foam model that holds the gap between knees so the hips remain neutral. The ribcage support should be a small, soft wedge or rolled towel placed under the left lower chest, just above the waistline, to prevent the left ribcage from collapsing inward. For head support, use a medium-thickness pillow that keeps the neck in line with the spine, neither propped up too high nor allowed to drop. If you have an adjustable bed, set the head section to achieve the 15 to 20 degree angle. If you don't, a 7 to 9 inch bed riser or a 20 to 25 centimeter foam wedge under the mattress at the head end will work. Step-by-step setup as you prepare for bed tonight. First, lift the head of your bed or place the wedge so that your upper body will rest at about 15 to 20 degrees. Measure roughly 7 to 9 inches of elevation at the head of the mattress. This is the sweet spot that helps breathing and venous return without creating excessive pressure on the lower back. Second, lie on your left side and place the firm knee pillow between your knees. The goal is to keep your hips stacked so the pelvis does not rotate, which would twist the spine. Third, slide the small ribcage support under the left lower ribs to gently lift that side of your chest. This reduces compression of the left thorax and improves lymphatic flow. Fourth, position a medium-thickness pillow so your head is neutral, ears aligned roughly with the shoulders. A small cervical support roll can help maintain neck alignment. Fifth, about 30-60 minutes before bed, spend 15 minutes with your legs elevated above the level of your heart. Lie flat on your back on a couch or bed and prop your calves on 2 pillows or a single wedge so the feet are higher than the heart. This preps the circulation by draining pooled blood from the legs before you settle into your left side position. Introduce these elements gradually. A practical approach is to add one change every 3 nights. Start night 1 by shifting to the left side with a knee pillow. Night 4, add the torso elevation wedge. Night 7, add the ribcage support. Night 10, begin the pre-sleep leg elevation routine. This gradual plan reduces the chance of waking discomfort and helps your body adjust to movement patterns. Many patients report being able to adapt within 2 to 3 weeks if they introduce the support stepwise. There are 3 common mistakes people make that undermine the benefits. First, using regular bed pillows stacked under the head instead of elevating the torso. That only tilts the head and leaves the chest and diaphragm unsupported. If you do this, you may still have airway collapse and persistent venous stasis despite a higher head. Second, elevating the head too much or sitting upright, more than about 25 degrees shifts pressure to the hips and may worsen lower back pain and reduce compliance. Third, trying everything at once, adding a wedge, rib support, leg elevation, and a brand new mattress at the same night, often leads to poor sleep and abandonment of the plan. The gradual implementation I described helps avoid those pitfalls. Let me share a few patient stories to put this into context. These are real people I've treated. I use first names to protect privacy and to show how individualized responses can be. Shirley came in concerned about palpitations that often woke her around 2 or 3 in the morning. She was on no blood thinners and had controlled blood pressure, but she slept mostly prone, on her stomach. We tried a left-side arrangement with a firm knee pillow and a small rib support. Over the next month, she reported significantly fewer nocturnal palpitations and better morning energy. She still followed her medication plan. This was an adjunct that helped her symptoms feel more manageable. Gerald had a documented non-dipping nighttime blood pressure pattern, meaning his blood pressure didn't fall during sleep as it should, and his doctor was worried about higher long-term risk. After adapting the left side plus 15-20 degree torso elevation protocol and addressing some sleep apnea issues with his sleep clinic, his nighttime blood pressure profile improved on repeat monitoring after a few weeks. Again, this was part of a package that included optimized medications and sleep-disordered breathing treatment, not the only change. Norma suffered from frequent morning headaches and daytime fogginess. She'd been waking to use the bathroom several times a night and noticed ankle swelling in the mornings. We introduced the pre-sleep 15-minute leg elevation and the left side protocol gradually. Over the next month, she reported less morning swelling, clearer mornings, and fewer nocturnal trips to the bathroom. Raymond had a prior pulmonary embolism and was understandably anxious about clots. After clearance from his hematology team, we used the positional plan cautiously while monitoring symptoms and leg swelling. He reported subjective improvement in leg sensation and anxiety about nocturnal events, and his team kept him on anticoagulation as directed. Those stories illustrate that positional change can be a helpful, low-risk adjunct, but always within the broader medical plan. You'll want to track objective and subjective metrics so you and your clinician can see if the change is helping. For a 30-day challenge, I recommend recording 4 daily measures: ankle swelling in the morning, photograph or measure ankle circumference if possible, morning clarity or brain fog on a simple 0-10 scale, nocturia frequency, how many times you get up to urinate at night, and general daytime energy on a 0-10 scale. Keep a simple nightly note. Position used, whether you did the pre-sleep leg elevation, and any new or worsening symptoms like breathlessness or chest pain. After 30 days, bring that log to your clinician. If you're on anticoagulation, recently had a thrombotic event or have significant lung disease, do this only after a medical check-in. A few more technical points about how the physiology works may help you stick with it. Venous return from the legs depends on the calf muscle pump, valves in the leg veins, and the pressure gradient back to the heart. when the torso is elevated modestly and the body is rotated to the left. Gravity assists blood venous flow toward the heart, and the left-sided lymphatic drainage, which collects a large proportion of the body's lymph, is less compressed. We also know that nitric oxide production declines with age and that the aorta loses elasticity. These changes mean that subtle mechanical factors during sleep make a bigger difference in older adults than in younger people. The combination of left lateral position and moderate elevation tends to reduce venous stasis, help lymphatics clear, and favor a more physiologic nocturnal blood pressure pattern. It is the combination, position plus elevation plus targeted supports, that produces the best mechanical outcome, which is why I insist on the full setup rather than recommending left-side sleeping alone. You may wonder about mattresses, recliners, and other sleep aids. A very soft mattress that allows excessive sinkage around the hips can throw off spinal alignment. If you sleep on your side and your hips sink too far, consider a slightly firmer surface or a thin foam topper to provide hip support. Recliner positions that let you sleep with your knees bent and torso high may be comfortable, but do not create the same alignment and can promote stiffness. Adjustable beds aligned to the 15-20 degree torso elevation are ideal. Avoid the temptation to pile pillows under only your head. Again, torso elevation is the key mechanical change. There are groups of people for whom this recommendation needs careful oversight. If you have severe congestive heart failure with fluid overload, talk to your cardiology team before elevating the torso overnight. Sometimes different strategies are needed. If you recently had major spinal surgery or significant hip replacement surgery, the positioning needed for healing may conflict with this protocol. Coordinate with your surgeon or physical therapist. If you have severe chronic obstructive pulmonary disease or are oxygen dependent, changes in the way your chest is positioned can alter breathing mechanics. Consult your pulmonologist. If you are on anticoagulation for atrial fibrillation, prior clot, or mechanical valves, discuss positional changes with your prescribing clinician before making significant adjustments. The positional change is not a reason to alter medications, but your team may provide useful individualized guidance. Let me address questions I get every week. Does this guaranteedly prevent stroke? No single intervention guarantees prevention. But there is growing evidence that nocturnal hemodynamics matter, and altering those mechanics can be one part of a comprehensive strategy to reduce risk when combined with medication, blood pressure control, sleep apnea treatment, and lifestyle measures. Could this replace anticoagulants or a CPAP machine? No. These therapies remain essential where indicated. Is this uncomfortable? Initially, some people find the rib cage support odd, or the wedge makes them feel unfamiliar. That's why we introduce changes gradually. Give your body 3 nights to adapt to the knee pillow, another 3 for the wedge, and so on. If you decide to try this, follow the gradual plan and track the 4 metrics I mentioned. Be patient with your body. Some people notice subjective improvements, fewer palpitations, less morning swelling within a week. Objective changes in nocturnal blood pressure patterns or imaging markers of vein health take longer and require medical testing. To recap the simple checklist you can follow tonight, set the head of the bed to roughly 15-20 degrees, about 7 to 9 inches elevation. Lie on your left side, place a firm knee pillow between your knees, add a small rib cage support under the left lower ribs. Use a medium thickness pillow to keep the head neutral. Do a 15-minute leg elevation, 30 to 60 minutes before bed. Introduce items one at a time every 3 nights. Track ankle swelling, morning clarity, nocturia frequency and daytime energy for 30 days, and bring the record to your clinician. Before I finish, a final note on evidence. There are multiple lines of research that inform this approach. Sleep studies showing relationships between position and apnea, Cardiology studies linking non-dipping nocturnal blood pressure to higher event rates. Hypertension, JACC. Vascular surgery literature on positional effects on venous flow, J-Vasc-Surg, and aging neuroscience work that explains how lymphatic and glymphatic drainage changes with posture. Frontiers in Aging Neuroscience. A 2023 combined protocol study brought several of these elements together and proposed practical positional measures for older adults at risk. The literature supports the plausibility and safety of modest positional change as an adjunctive strategy. It does not claim a universal cure. Use it as one part of an evidence-informed plan with your medical team. If this message has resonated, share it with one person you care about who is over 60 or cares for someone over 60. Many people never hear this mechanical part of heart risk discussed. Leave a comment telling me what your usual sleep position is now and whether you'll try the 30-day challenge. I'll be watching the comments and plan to revisit this topic with common questions and troubleshooting based on what you report. Remember, you're not broken. Aging changes anatomy and physiology in predictable ways, and many of those changes respond to simple mechanical fixes. Left side sleeping with modest torso elevation, targeted supports, and a brief pre-sleep leg elevation is a low-cost, low-risk strategy that may reduce the mechanical contributors to nocturnal clot and stroke risk. Try the stepwise plan, track your results for 30 days, and discuss the findings with your clinician. If you notice new or worsening chest pain, sudden shortness of breath, swelling that's asymmetric or painful, significant dizziness, or any alarming new symptom, seek immediate medical care. Share this with someone who might benefit. Subscribe if you want more practical, evidence-based heart care tips for older adults, and come back in 30 days to tell us what you observed. I'll be here to help troubleshoot and to review the data with you. Thank you for taking a few minutes to consider a change that could make your nights and your mornings safer and more comfortable.